Hello? Okay. So welcome everyone and thank you for joining me today. Today we're going to look at some of the key anesthetic principles and how they are reflected by the anaesthetic position statements and professional guidelines. As perioperative nurses, we work alongside anesthetic teams every day, caring for patients through different anesthetic stages. So having a clear understanding of the guidelines and position statements will help us recognize our role and be effective in our responses. So in this session, we'll also discuss the important concepts around anesthetic principles like anticipation, vigilance, continuity of care, and the anesthetic continuum, and how your role as a perioperative nurse impact every stage of the anesthetic journey for the patient. So the aim is not to undermine the anesthetists, but to strengthen our understanding of these principles and how they apply to our everyday practice. So we'll take a look at the guidelines and the reasoning behind them and what it means for us as nurses. I'm going to share my slides just so we could follow today's discussion. We're going into just preparing my slides. Not sure if you can see that just yet, but it's this one. Hope you can see this. So, theatre side nursing, this is the channel that is built as a resource for perioperative nurses out of what I thought I needed when I started my perioperative journey as a nurse. So, anesthetic principles that every nurse needs to know. So, these are the things that nobody tells you until you're already in practice. Especially in recovery, you'll find this out as you go through your career. So, why do nurses need to learn the anesthetic standards? So, if you're touching a monitor, if you are using a drug chart, or if you're helping with a deteriorating airway, or if you're helping in a crisis situation in theater or in recovery, congratulations. The anesthetic standards already applies to you. So why nurses should read the anesthetic standards too? The Australian New Zealand College of Anaesthetists is the recognized professional body setting the clinical standards for anesthesia across both countries. And the position statements and the guidelines don't just apply to the anaesthetists. PG-18, so PG doesn't mean the rating for the movie or the TV show. PG-18 is what we call the professional guideline about that is set out by the governing body as a standard for healthcare practitioner under ANSCA. So PG-18, it's all about monitoring during anesthetics. It explicitly says, while this guideline is written for an anesthetist, It applies to any practitioner responsible for monitoring a patient during anesthesia. So this is a slide that has a snip of the PG-18. So you can see the purpose is clinical observation and assessments by vigilant anesthetists is essential for safe patient care. And the scope is anesthetist, medical practitioner, and practitioner are used interchangeably in this document. So although it is primarily aimed for anesthetists, any practitioner responsible for patient monitoring during anesthesia should follow the guideline. Therefore, it applies to us, nurses. So we all know what monitoring means. I'm guessing you all would be familiar with that at this point. So you're monitoring the variables, like the parameters that the patient of the patient's vital signs, and then you'll give, based on that, you will respond and give interventions if it's needed, and just continually be vigilant with your observations of the patient. So this PG-18 is a good professional guideline document to go by. If you're having any issues or if you have any questions about what the standards are as a nurse in a perioperative practice. Okay, some of you would say perioperative nurses should practice according to ACORN and ACPAN standards. So ACORN is your Australian College of Operating Room Nurses, and ACPAN is your Australasian College of Peri-Anesthesia Nursing Standards. So they are the two main governing bodies that put out the regulations or the standards for how nursing, perioperative nurses should practice. But what I'm saying here is anesthetic principles applies, and we should also know, as nurses, we should know the Australian and New Zealand College of Anaesthetists guidelines, only because ANZCA writes anesthetic standards. So ACORN and ACPAN don't change the standards from ANZCA. They build their own to apply to nursing practice around the ANZCA requirements. So ACORN and ANZCA actually cite, ACORN and ACPAN actually cite ANZCA as they write their standards. So what ANZCA write, they write what is true for anesthetic to be safe, like vigilance, monitoring, continuum, the anesthetic continuum, and the continuation of responsibility for patient safety. That's what they write about. ACORN and ACPAN don't rewrite any of the ANZCA standards. They translate it as to how it will apply to nursing staff that is in operating theaters or is in recovery. So what it does in real time, it creates a standard for how we should practice. So perioperative nurse practice according to ACORN and ACPAN. So example, ACORN's role definition in anesthesia and perioperative care. They cite ANZCA PS 59. So if you have time today, you should Google PS 59 ANZCA, and then you compare it to ACORN's role definitions. ACORN's own evidence guide lists ANZCA's guidelines on monitoring. Also, professional standard document states that adherence to ANZCA's monitoring guideline is what enables the anesthesia nurse to provide quality, consistent, and safe anesthesia. So, the gold standard from ANZCA. This is written not according to number, but written as if you were going through the patient journey. So at every stage of anesthetic, from the time that the patient arrives, they get their check-in, they get looked at by the anesthetists, and then the standards for the sedation or the general anesthetic, it's all in there. The PS55, the minimum requirements for facility to safely administer anesthesia is also included, which is also a part of that is how the anesthetic nurse prepares all this equipment. PG18 is monitoring during anesthesia, and PSO4 is for post-anesthetic care. So as you can see, pre-anesthesia, patient preparation as they arrive is the first stage of anesthetic continuum, and then it will the assistant for the anesthetist is the anesthetic nurse, their role, and that will explicitly say what is expected. Guideline on procedural sedation, it tells you exactly what is required. Sometimes the procedural sedation doesn't always happen in theater, though. It can happen in ED. It can happen in a dentist office. And then, minimum facility for administration of anesthesia requirements, monitoring, and post-anesthetic care. So how does nursing fit in the standards or guidelines? So the PG07, your pre-anesthetic consult, the story starts there, even before they sleep. So as you do your check-in as a nurse, you're checking for a little bit of history, like say the medication, what medical issues they have, the allergies, when did they last eat, the first clues. Have they had any, when they're telling you a story, they would sort of pause and think, does it really relate, or doesn't it relate to what, the safety standards that the patient would go through in theater? Assistant for the anesthetist, 2 hands, 1 job. So an anesthetic nurse is actually named in the standard. So you're you're not just an extra pair of hands, you're an extra pair of brain in the room. You're an extra brain in the room. So it's not just one person, there's more than one that's helping with keeping the patient safe. Procedural sedation. So procedural sedation, wouldn't you think that's endoscopy, ED, cath lab? Still, vigilance. Vigilance is very, very important under procedural sedation. The minimum facilities, if you don't have all the equipment, you don't have all the drugs that you need to keep the patient safe, not just to put them to sleep. The oxygen, the suction, the airway, the different types of airway, the airway rescue kits. If you don't have them, no go. Just look up PS55. So the PG18, your eyes are the real monitor. The screen is the backup. So you can actually literally see the deterioration before the screen shows you it. Recovery, post-anesthetic care. It's not an afterthought. It is a standard written with the nurses in mind. Does anyone have any questions at this point? So what are the anesthetic principles? It really rests in what you do as a nurse in the patient's journey. So anticipation means anesthetic care is proactive, not reactive. If you understand the risks, you can anticipate the issues that may come up, and you can prepare for those complications and put interventions. Sometimes people even get canceled on the day if they anticipate that it's not going to be safe for that patient. Vigilance. You become the observer of the patient and the patient advocate. So you recognize the subtle changes and allows timely interventions. Continuous care. uninterrupted observation and care by trained clinicians. Safety depends on maintaining that continuation of responsibility. So as you hand over to the next nurse, from the time you do the check-in, then the anesthetic nurse comes in, and then the anesthetic nurse brings the patient into theater, and you do your timeout. And from there on to recovery, that's continuation of care, handing over within the anesthetic continuum. Next is your anesthetic continuum. Sedation and general anesthesia are the two there are many more different types of anesthetic. But when you're doing sedation and general anesthesia, there are different points in time where when patients rapidly move between these levels. So your observation really matters as to what level they're in. The awareness that nobody talks about. So this is very, very interesting. Awareness can occur at induction or emergence in 2 out of 3 cases. So this is from the National Audit Project. I think this is in Great Britain by the Royal College of Anaesthetists or Association of Anaesthetists. So vast majority of documented awareness cases involve auditory perception specifically at those transition points as the patients go under and as they emerge out of anesthetic. There's what we call explicit recall. The patient consciously remembers a specific conversation or event. So this actually happened to me as I went under. It was unexpected. Was going to be just spinal for my procedure. And then my blood pressure dropped. I could hear everything that was going on. I know exactly what they were talking about, but I could not move and could not speak. I just didn't have the strength. And then they put me on a GA on top of the spinal. So that's one explicit recall. I have experienced it myself. There's implicit memory. Some patients won't have a conscious recall at all, but the brain still processes what the auditory nerves heard. It can quietly shape the mood or behavior of the patient afterwards. So the patient that you see that's a little bit restless or a little bit agitated on emergence or in recovery, there may be something to it. So the old teaching that says to you, talk to them like they're awake, it's not a superstition. It's grounded on the mechanism that I'd spoken to you about, the explicit and implicit memory. So then any unexplained anxiety, tearfulness, or if a patient's fixating on something oddly specific in recovery, sometimes it traces back to something said at induction or emergence. So when you're talking to your patient, whether or not they're conscious or unconscious, it might carry something. It might transfer something emotionally to the patient, even they can't consciously remember it at that point in time. So anesthetic awareness may turn into a legal or complaint issue if you're not careful. So that is something that we as nurses really need to be mindful of. So the references that I have here, you can take notes of it, and this recording is going to be available online. So at this point, are there any questions? Okay, so I think we're all done. Thanks for your participation. Until next time.